Assalamu alaikum wa rahmatullahi wa barakatuh. I would like first of all to thank you and thanks Dr. Mazen Jumani for having me here with you today. My name is Ahmad Hawasli. I am a board certified periodontist working currently in Virginia, United States. I would like to share with you today one of my presentations talking about the soft tissue biotype in implant treatment planning. So we would like to see what's the importance of the soft tissue biotype in implant dentistry. So what is the importance of the mucogingival tissue around the implants? How much soft tissue thickness do we need? And what are the treatment options for the mucogingival deficiency? So during this presentation, I will try to answer these questions. And just to show you the importance of the soft tissue around the dental implants, and that we need to measure the soft tissue thickness and consider the soft tissue biotype before we place our implants. So there are four main variables that have been shown to affect the early marginal bone loss around dental implants. So we have the occlusion. As we know, if we have heavy occlusal forces, premature contact, or any occlusal trauma on dental implants after we restore it, we will see by the time some bone loss around the neck of the implants. So this is one of the factors that need to be considered when we do our implants. Also, we have the polished implant surface. As we know, some implant companies come with a polar or smooth surface neck, which what we call the soft tissue level implant. And when we place this implant, we don't want to have the smooth surface be placed subcrystally, because we will see it by the time also bone loss around this polished surface. As we know, the osteoblasts don't like the smooth surface, but they like the rough surface, and that's why we see a lot of study and research how to treat the implant surface and how to achieve rough implant surface in order to improve the osseointegration around the dental implants. And also we have the location of the microgap. As we know, there is a microgap exists between the abutment or the abutment and the implant neck, or the implant platform, sorry. This microgap harbor bacteria, and we know by the time also we can see some bone loss around the neck of the implant because of the pumping action of the microgap. So some studies showing that this microgap can be placed supracrystally in attempt to put the microgap or the bacterial action away from the bone and to minimize the bone loss around the neck of the implant. And then we learn about the platform switch, in which they place the microgap inward the implant away from the surrounding bone in attempt also to minimize the action of the microgap against the bone around the neck of the implant. And finally, also we see this research talking about the importance of the soft tissue thickness around the dental implants and how they affect also on the marginal bone around the implant platform. So, as we know, there is classification for the soft tissue or the gingival biotype. We have the thin biotype and a thick biotype. As we can see on this picture, the thin biotype people, they usually have a thin soft tissue, lack of adequate attached keratinized tissue. We will see also sometimes some gingival recession. The scalloping, also there will be scalloping around the neck of the tooth, as we can see on this picture. Sometimes we can see also like the roots showing through the soft tissue. And it's very important also the shape of the tooth. The tooths are usually, or the crown of the tooth are usually triangle shape. They have incisal contact. So the contact between the crown is more incisor located, and this is also very important to consider it when we do implant in anterior aesthetic zone and how to restore these implants, because sometimes we end up with what we call black triangle with these patients. So it's very important to know our patients if they have a thin biotype or thick biotype before we place our implant, because this will entail us how we're going to place our implant and what's the treatment modality that we need to proceed with. So the thickness of the soft tissue with these people is less than 1.5 millimeter. Let's see the thick biotype. The thick biotype people, they have, as we can see on this picture, they have good amount of the keratinized tissue, thick soft tissue, which is more than 2 millimeter, and the shape of the crown is square shape, and they have a broad contact area between the crowns, which is located more apically, and this is more easier to restore the implant with these cases because we will have less chance to have a black triangle between the crowns because of the broad apically located contact. And these people, when they have periodontal disease, they usually have a periodontal pocket rather than the gingival recession or click attachment loss. Now, also, it's very important for people who do braces, orthodontic treatment, or Invisalign to differentiate between the thin biotype and thick biotype, because if we are doing Invisalign or ortho on thin biotype and we move the teeth fast, these people will end up with significant gingival recession and tooth mobility. Because also, we will see during this lecture, when we have a thin soft tissue biotype, usually these people have a thin hard tissue biotype and thin bone. So also, it's very important to differentiate between these two kinds when we do also the orthodontic treatment. So gingival biotype and labial plate thickness, as we know, according to many studies, there is a relationship between the soft tissue biotype and the thick and the hard biotype. A thicker biotype has been found to be indicative of a thicker buccal bone plate. And they found also there's association exists between the gingival biotype and the labial plate thickness. It means that if we have a thick soft tissue, as we can see on this picture, we will have a thick also bone. So we can see there is good buccal lingual thickness of the ridge, and we can appreciate the appearance of the soft tissue. We have a flat, a thick gingival soft tissue. This is an ideal case to do immediate implant placement because it's easier to restore, and it have a better success rate than if we do immediate implant with a thin biotype. Also, there is a relationship between the gingival biotype and crystal bone loss. Many studies showing that when we have a thin biotype, and if we place this implant with thin biotype, we will see some bone loss around the neck of the implant. A thick tissue, which is more than 2.5 millimeter, can avoid significant crystal bone recession. So, according to some study, they're showing we need to have more than 3 millimeter thickness of the soft tissue in order to maintain the level of the crystal bone around the neck of the implant. So it's very important also to consider the thickening of the soft tissue. We will talk about that later on during this presentation before we place our implant if we have a thin biotype. So this one of the study, they showing there is a relationship between the soft tissue thickness and the crystal bone level around dental implant. And with this study, they try to see the effect of the micro gap on the bone loss around the neck of the implant, but they have two different groups: thin biotype, people who have thin biotype, and people who have thick biotype. And with this study, the tester group, they place the implant supracrystally about 2 millimeter. So they didn't submerge the implant. They didn't put the implant subcrystally. They leave it about 2 millimeter above the bone. And the control group, they place the implant at the bone level. However, with a group that having implant supracrystally, they divided them into thin biotype and thick biotype to see the effect of the micro gap, as we discussed before, on the crystal bone when we have a thin biotype and when we have thick biotype. Are we going to have the same result or not? So they found that in group A, which is the thin mucosa, we'll see here group A, thin mucosa, there was 1.6 millimeter bone loss on the mesial aspect, on the mesial aspect of the implant, and we have 1.2 on the distal aspect. So there is about 1.5 millimeter bone loss. Even if we place the implant above the bone and we have thin mucosa, we will have some bone loss. However, the mean bone loss in the test group, which is the thick mucosa, it was 0.2 millimeter and 0.1 millimeter, sorry, on the distal aspect. So there is significant difference between both groups. So this is, as a conclusion for this study, they found that the initial gingival tissue thickness at the crest may be considered as a significant influence on marginal bone stability around the implants. If the tissue thickness is 2 millimeter or less, crestal bone loss up to 1.45 millimeter may occur despite the supracrestal position of the implant abutment interface. Let's see another study. So here also, after 1 year, they did also the study, but here they test the effect of the platform switch. Also, they want to see the effect of the platform switch connection between the thin biotype and the thick biotype. So they have the control group, which is the butt joint connection, regular connection between the implant and abutment, and the test group, which is the platform switch. They place both group. They place it in a thin biotype. So we have the platform switch implant placed in a thin biotype, and the regular connection implant placed also in a thin biotype. And let's see what they found. Bone loss around the test implant, which is the platform switch, was 1.8 millimeter on the mesial side and 1.7 on the distal aspect. The control implant, however, the marginal bone resorption, also they found 1.6 millimeter on the mesial and 1.7 on the distal. So there's no significant difference between the two groups. So despite we have a platform switch, as we know, the platform switch should minimize the bone loss, but if we have a thin biotype, it will not have any effect. So there will be some bone loss. So with the limitation of this pilot study, it can be concluded that the implant with a platform switch didn't preserve the crystal bone better in comparison with the implant with the traditional implant abutment connection. So let's see other study. Now here they have three groups: thin biotype, thick biotype, and thin biotype, but they use alloderm or soft tissue graft to thicken the soft tissue. So after 1 year follow-up, group A, which is the thin biotype, they found there is 1.6 millimeter also bone loss on the mesial and 1.8 distally after 1 year. Group B, which is a thin group, but they use alloderm soft tissue graft to thicken the tissue. Here we see that there is 0.3 millimeter bone loss on the mesial and 0.3 also on the distal. So it dropped down from 1.6 to 0.3 millimeter bone loss, and it's a significant difference. C group, which is the thin biotype, C group, which is the thick biotype or the thick biotype patients, they found the bone loss is 0.4 millimeter. So at the conclusion, it can be concluded that the thin mucosa may cause early crystal bone loss, but their thickening with allogenic membrane may significantly reduce the bone resorption. Implants in naturally thick soft tissue experience minor bone remodeling. So it's very important when we open our flap to measure the thickness of the gingiva. If we have a thin gingiva, we may consider doing some soft tissue graft or alloderm graft at the same time of the implant placement in order to minimize the crystal bone loss in the future. So why this happen? Why when we have a thin biotype we will see bone loss around dental implants? So as we know, there is what we call biological width around the natural tooth, which consists of epithelial attachment and connective tissue attachment. So there is what we call Charpit's fiber that insert into the cementum of the root. So we have direct contact or direct connection between the gingival fiber and the root surface. In implant, we don't have that. We only have a long junction epithelium with a hemidesmosome attachment, but we don't see or we don't have direct connection between the gingival connective tissue fiber with the implant surface. The fiber run like a pearl and a spiral around the implant. There is no horizontal direct connection, and that's why the connection of the tissue around the implant is very weak, and the implant can have peri-implantitis easily because of lacking of the direct contact and attachment of the soft tissue with the implant surface. So, in non-submerged and submerged implants, the most coronal bone to implant contact is consistently located approximately 2 mm below the microgap. So, according to this study, they found wherever we place our implant, we're going to have the bone loss about 2 mm below the microgap, below the connection of the implant with the abutment. However, if the tissue thickness is 2 mm or less, formation of the biological width around the implant will involve the bone loss. So that's why we will see bone loss around the implant if we have thin biotype, because there will be what we call the biological width formation on the expanse of the bone around the neck of the implant. More tissue in height are required around the implant than around teeth for biological width to protect the underneath lying bone. And as we can see on this picture, so around the implant we will have what we call the long junction epithelium here, and then we have the connective tissue. So the distance from the crest, from the gingival margin to the alveolar bone crest is about 3.8 mm, about like 4 mm. However, the distance of the biological width around the tooth is about 3 mm. So there is 1 mm extra, the 1 mm extra height around the implant. And that's why we need to have more soft tissue around the implant in order to protect the crystal bone. So the height of the soft connective tissue was significantly greater around the implant than around the teeth. This is another study by Turner. Here, just to show you, there is also what we call horizontal biological width around the dental implants. So around the natural tooth, we only have a vertical biological width, but on implant, we have also vertical and horizontal. And that's why we want to keep our implants at least 3 mm away in order to minimize the bone loss. If we place the implant close to each other, less than 3 mm, there will be overlapping of the biological width, subsequently crystal bone loss, and papilla recession and black triangle formation between the crown of the implants. So according to this study here, the result demonstrated that the lateral bone loss was 1.3 mm from the mesial implant shoulder and 1.4 mm from the distal implant shoulder between the adjacent implant. In addition, the crystal bone loss for the implant with a greater than 3 mm distance between them was 0.4 mm. So if we have 3 mm or more, we will have less bone loss, which is about 0.4 or 0.5 mm, while the implants that had distance of 3 mm or less between them, we will have crystal bone loss about 1 mm. So this is also very important to consider when we do multiple implants together. This is also another study. This is systematic review. They're showing that also implants placed with the initial thicker peri-implant soft tissue have less radiographic marginal bone loss. Here I just want to show you on the introduction of this study. Here they're saying traditionally marginal bone loss less than 1.5 mm was defined as a reference point for successful implant treatment after 1 year loading. First, when we start learning about the implant, they were saying if we have less than 1.5 mm marginal bone loss after 1 year of restoring the implant, this is considered as successful criteria. But now, with the use of the new surface technology, new implant design, and the availability of new research on factors affecting the bone remodeling, this concept should be redefined. Having 1.5 mm of the marginal bone loss is no longer acceptable during the first year of function. So we need to see zero bone loss after one year. So let's start with the clinical cases here. This is one of my clinical cases. As we can see here, the implant was placed in a thin biotype. Patient came back after 3 months to do stage 2, and there is small fenestration on the crystal gingiva because of the thin soft tissue. Here I place the implant without doing any allograft or any soft tissue graft. And this is during the stage 2 procedure. So we put the healing abutment. I measured the sulcus around the implant, and we can see there's like 3 millimeter pocket around the implant. Now let's take a look to the X-ray. This is at the time of the implant placement. The implant was placed crystally at the bone level. Now I took X-ray after I did the stage 2, and here we can see there is some bone loss around the neck of the implant here. So while we have that, there is no peri-implantitis, there is no occlusal trauma, and the implant is platform switch design. So why we have bone loss here after 3 months of the implant placement? Well, because we started initially with thin biotype. So when there is fenestration of the crystal bone, there's bacterial leaking with the saliva leaking around the implant, around the neck of the implant. Subsequently, there will be physiological, biological wedge formation on the expense of the bone around the neck of the implant. This is the final restoration, and this is after 1 year of the restoration. So the bone level is stable now after the stage 2. Yes, we have like 1.5 to 2 millimeter bone loss, but now it's stable. But we want to see 0 bone loss. So we don't like to have any exposure of the thread of the implant, because this may cause bacterial accumulation by the time and can initiate peri-implantitis and problem around the implant. This is another case. We placed 2 implants on the lateral incisor. We can see from this picture, this patient has a thick bone and thick biotype, right? We can see how the bone, the ridge is wide, and how the soft tissue is thick. So here we decide to do stage 2 with apical positive flap. Here we move the keratinized tissue from the crystal aspect to the buccal aspect, as we can see here from this picture. So we place the healing abutment. We did apical positive flap. This is after 2 weeks healing time. 3 weeks, we can see how the tissue is healing. It's like we did CT graft or free soft tissue graft. And here's after 2 years of the restoration. Now let's take a look to the X-ray. We can see there is maintained bone level around the neck of the implant. We can see here there is a thick soft tissue around the neck of the implant on the buccal aspect. This is on the other side. We can see the bone level is maintained after 2 years, because we started initially with a thick soft tissue biotype. And of course, we take care of another factor that we talk about, which are the occlusal trauma, the micro gap, the implant design, and so on. So all the factors need to be considered together, and we don't want to miss any of these factors. So the soft tissue biotype is not only a factor that causes bone loss. There's another factor. It's one of the factors that need to be considered. This is another case. Also, we started with a thick biotype, and this is apical positive flap, and we can see how we create good band of thick tissue on the buccal aspect of the implant by doing apical positive flap, and this is after 1 month healing. So the implants now are ready to be restored. This case, there's significant bone loss around the apical part of the root of the lower anterior teeth. We can see from the CBCT there is no bone around the root of the tooth, so there's a significant bone loss around the lower front tooth. So what we did here, we did ridge augmentation. Here I used like an alloderm as a membrane. So I use alloderm with fixation screws to stabilize the membrane, as the alloderm, and we use FDBA bone graft. And here, this picture at the re-entry of the site, and here look at the soft tissue thickness. So we have 4 to 5 millimeter thickness of the soft tissue, because we use an alloderm to thicken the soft tissue. And we have, of course, good bone formation. So we place our implant. This is during the stage 2. We can see how much thickness do we have around the implant. And the bone level looks fine. So same thing, apical posterior flap. And look at the healing time here after 1 month. So we can see there is good band of the thick keratinized tissue around the neck of the implant, which will protect the crystal bone because we established the biological weights supracrystally. So this is our target. We want to keep the biological weights around the implant supracrystally, not infracrystally. Now, gingival biotype and aesthetic. Of course, when we have a thin biotype, we may end up with aesthetic problem after we restore this implant. So dramatic alveolar resorption in the apical direction is possible in patients with a thin biotype, which may result in gingival grayish color and aesthetic problem. However, some studies talk about tissue discoloration. Titanium induces the most prominent color changes in thin biotype when we have 1.5 to 2 millimeter soft tissue thickness. No tissue discoloration was observed when the tissue thickness is 3 millimeter. So also it's important to have a thick tissue around the implant to minimize the tissue discoloration by the time and aesthetic problem. It's preferable to use zirconium for thin peri-implant mucosa to avoid color changes of the mucosa. So also when we have a thin biotype, they recommend to use zirconium abutment, which will cause less tissue discoloration than titanium abutment. Also, we will have a problem with papilla formation, as we mentioned before during this presentation. Papilla between immediate single implants and adjacent teeth is significantly associated with the gingival biotype. Patients with a thick, flat mucosa tend to maintain the implant papilla height. So also the thick biotype will help to maintain or create the papilla between the restoration. Of course, keep in mind, we need to have not more than 4 to 5 millimeter height between the contact point and the crystal bone. So there's a well-known study to turn out. They said if we have more than 4 to 5 millimeter distance between the contact point and the crystal bone loss, we will have less chance of papilla formation, and we will end up with a black triangle. So let's take a look to this case. This patient came with gingival recession, exposure of the neck of the implant, aesthetic problem. Here, I think the dentist places the implant too buccally and end up with bone resorption and gingival recession, and subsequently, aesthetic problem. So here to treat this case, I decided to go with a city graft. So we rise the flap, and here it's very important to clean the thread of the implants, like as we deal with the pre-implantitis, before we place the graft. So usually I use titanium brush. There's titanium brush with irrigation, so we can clean the surface with titanium brush, and sometimes we can add some chemical like tetracycline to disinfect the implant surface. So here we can see we have a clean surface, and then we apply the city graft. Sorry, I don't have picture showing the city graft in place. So I took the city graft from the palate, and then I grafted the area with the city graft. Then I did coronally positive flap covering the area, and look at the picture now after 1 year. So we can see there is good thick tissue, and also we achieved some coverage of the exposed implant. And this is the picture showing the titanium brush that we use usually when we clean the implant surface. This other case came with peri-implantitis, upper anterior implant peri-implantitis. We remove the crown, we place healing abutment, and I decided to go with a flap to clean the implant surface. Now here we can see there's remnant of the cement granulation tissue. So we clean we clean everything, and we end up with this picture. We have a broad, wide bone defect around the implant. Look at the implant neck. We have here polished smooth surface. And this is one of the factors also that need to be considered. We don't want to have this smooth surface placed subcrystally. So here I decided to go with only city graft without bone graft. So I took a good thick tissue. So I applied here, as we can see on this picture. And then I did apical progeny flap, of course, here, because I need also to increase the thickness of the buccal tissue. So I placed healing abutment, and then I move the tissue and buccally and suture it. This is after 1 year healing. So we can see there is good thick tissue on the buccal aspect of the implant. Normal looking sulcus. There is no inflammation, no redness. So the site looks healthy. Now let's just take a look about what's the importance of the keratinized gingiva versus periimplantitis. So at the beginning we talked about the importance of the soft tissue thickness around the dental implant. Now it's also to mention it's very important to have attached tissue on the buccal aspect of the implant too. So according to this study, they found the presence of less than 2 mm of the keratinized tissue around the dental implant seemed to be associated with the periimplantitis. So if we place our implant and we don't have a thick buccal tissue, we only have a thin mucosa, this may also cause a periimplantitis by the time. And that's why I mentioned during my cases doing apical progeny flap, by which we move the keratinized tissue from the crystal aspect to the buccal aspect. This case came, this is 3 implants with a bridge. As we can see here, there's lack of the attached tissue, only mucosa. Patients complaining of difficulty on with brushing of this area. As we can see, there's shallow vestibule, there's no attached tissue. So the patient also has some tenderness on this area. So here we decided to go with free gingival graft to create good band of the tissue buccally around the implant. So we did the partial thickness flap and visceralplasty. Here we took a good band of tissue from the palate. Here we can see on the picture the small cut through the graft. This will help to expand the graft, as we can see on this picture. So now I can cover a wider area with the graft by doing these small cuts through the graft. So we stabilize the graft with a chromic gauge suture. This is after 1 year healing time. We can see there is mucogingival junction. We have a good band of the attached tissue. Now the patient is able to brush the area, and also we can see that we achieve some metal coverage with a free gingival graft. This is another case. We did 2 molar implants. We can see here there is lack of attached tissue, only mucosa, shallow vestibule. So here when we do stage 2, we can do apical progeny flap. We have to do free gingival graft to create a good band of tissue around the buccal aspect of the implant. This is the X-ray of showing the implant in place. And this is the picture showing the free gingival graft with the healing abutment. This is also an X-ray after we did the stage 2. And now this is after 2 months, so the implants now are ready to be restored. We can appreciate the amount of the keratinized tissue around the implant on this picture. This is another case. Implant was placed and restored, but there is lack of attached tissue, only mucosa. Patient complaining of food impaction, difficulty in cleaning this area. So we decided to go with the free gingival graft again. So we placed free gingival graft, and this is after 1 year healing time. We can appreciate the thickness of the tissue, and now the patient can clean the area efficiently. So there are risk factors for the facial gingival recession. So we know now thin soft tissue biotype can lead to gingival recession by the time around the neck of the implant. Also thin buccal bone plate. So when we have thin biotype soft tissue, usually we will have thin buccal plate also. So when we have thin buccal plate, also is a risk factor for gingival recession and exposure of the thread of the implant and aesthetic problem. Also, implant position and prosthetic design is another factor. So, if we place the implant toward the buccal more buccally, or if we tilted the implant more buccally, we will end up with bone loss and gingival recession because of the mal-implant position. Also, the prosthetic design, if we have the crown of the abutment is too bulky and pushing against the gingiva, this can cause gingival recession by the time too. So an aesthetic and natural-looking pre-implant soft tissue architecture is more predictable and easier to achieve in patients with a thick biotype and a flat gingival contour as compared to the patient with thin and scalloped biotype who are more likely to experience mucosal recession. The thick soft tissue enhance primary wound closure, provide vascularity, side protection, and stability for regeneration around the implant. The thick soft tissue biotype is more resistant to mechanical irritation and recession. So the thick biotype will act as a cushion, will provide better vascularity, and it's more resistant to any mechanical irritation and subsequent recession. This diagram taken from this study, the influence of the soft tissue biotype on implant aesthetic. Here, they're talking about how we can achieve a thicker band of tissue around the neck of the implant. So here they talk about the implant design using a smaller diameter implant with a platform switch and the implant position. So the implant, we would like to have it more palatal position and more apical position. Prosthetic design, we would like to have concave abutment profile on concave crown profile. Together, we will increase the thickness of the pre-implant mucosa. So also it's very important to, when we place our implant, to place our implant in a correct position, and when we restore our implant, to restore it correctly. We don't like to have a bulky contour crown or abutment. Have your abutment or crown have some concavity on the gingival aspect to allow more space for the soft tissue and prevent pressure on the soft tissue and prevent recession by the time. So treatment options for the soft tissue deficiency. We have apical position flap, as I showed you before during this presentation, free connective tissue graft, and a free gingival graft. Regarding the apical position flap, here according to this study, if we have 3 mm or less between the mucogingival junction and the neck of the implant, it's better to do apical position flap. If we have more than 3 mm distance between the mucogingival junction and the implant platform, we can do a punch technique. And this is a summary for this presentation. So when we have soft tissue biotype 1 to 2 mm, implant platform position should be placed 1 to 2 mm subcrystally and using platform switch to minimize the micro gap effect. Soft tissue augmentation is required using CT graft or alloderm. So when we place the implant, cover the implant with soft tissue grafts, with alloderm or connective tissue graft. And when we do the stage 2 and expose the implant, using apical position flap is recommended during the stage 2. However, regional graft in stage 2 can be done when lacking of attached tissue. As I showed you before during this presentation, when we don't have the crystally good tissue, we can do a free gingival graft when we do stage 2 instead of apical position flap. When we have soft tissue biotype 3 to 4 mm, implant platform position should be crystally. Soft tissue augmentation is not required. However, apical position flap is predictable during the stage 2. When we have soft tissue biotype 5 mm or more, like in the posterior maxilla, usually, so here we can put our implant 1 to 2 mm supracrustally and using the soft tissue level implants. When we do the stage 2, soft tissue, when we do stage 2, apical positive flap is not required, is an optional. And when we place our implant, the soft tissue augmentation is not required too. However, gingivaloplasty may need it in some cases during the stage 2. So sometimes when we do the stage 2, we have very thick tissue, like 6-7 millimeter. And we don't like also to have a very high soft tissue because this may create a pocket around the implant and make it difficult on the patient to clean around the implant and can cause a problem, can cause pre-implantitis in the future. So gingivaloplasty, usually we trim down the soft tissue around the neck of the implant. Ideally, we would like to have 4 to 5 millimeter maximum soft tissue thickness around the implant. So, finally, at the end of this presentation, gingival biotype can affect the result of the implant placement. Therefore, the gingival biotype should be evaluated at the start of the treatment plan. I would like to thank you so much for your attendance and for your listening to this presentation. And I would like to thank again Dr. Mazen Jumani. I hope this presentation was enjoyable, and I hope I provide some good information for you. Here is my contact information. You are welcome anytime to contact me if you have any question or if you need any consultation with any case you have. You are free to contact me. You are also welcome to follow me on the Facebook page where we can share some of the cases and have good discussion with our colleagues. This is just a picture of my kids. This is Martez, my son, and this is Salam, my daughter. Here also they would like to be a dentist like us, so I would just like to share this picture with you. Thank you again, and wish you have a good evening. And inshallah we'll meet again and talk to you soon. Assalamu alaikum wa rahmatullahi wa barakatuh.